Okay, good evening, everybody. I am Kristoff Corten. Jeroen and I, we would like to welcome all of you to our second webinar, the webinar on efficient surgery. Efficient surgery specifically focused for the direct anterior approach. We have been able to fine-tune the direct anterior approach over the past years in our hospital to the efficient direct anterior hip. And this is basically all based on a concept, the efficient surgery concept that we have developed over the years and that we want to share with everybody all over the world, so that surgeons, nurses, surgical teams, and hospitals can really also benefit from the experience that we have gained over the past years. This webinar is not a typical webinar for surgeons. In terms of, we will focus a little bit on the surgical approach, but mainly we focus on those surgeons that are interested in driving the efficiency in their own OR for multiple various reasons. I strongly believe that we as surgeons and we along with the industry, along with our nurses and anesthesiologists, that we really need to protect our quality of care. We need to protect healthcare because more and more administrators, ministries of health really are pushing us towards lower costs, towards decreasing costs in revenues or in streams for hospitals, so that healthcare really becomes under pressure. This is really what we feel here in Europe. And I also think that there are a lot of opportunities and a lot of threats in the States. In the States, we see with the surgery centers that many surgeons really want to drive efficiency in their OR, but they are not able, or they're not willing, of course, to compromise in quality of care. We need to make sure that our healthcare system remains sustainable, and we also need to make sure that we really can protect our quality of care. And I strongly believe that we as surgeons, as a community from the orthopedic industry, can do it ourselves as long as we are proactive. And that is what we want to share with you today with this webinar. Later on, new webinars will come as well. Other webinars that also focus on various steps of various parts of the surgical technique will also be presented. Along with Jeroen. Jeroen is one of our engineers. He's also the CEO of a company called Dille. Dille is Digital Efficiency in Orthopedics. And Jeroen really helped us to actually drive the efficient surgery concept now into an efficient surgery solution. A solution for surgeons, many surgeons all over the world, in order to help efficiency or help driving efficiency in their OR. So the webinar in total is about 41 to 42 minutes. So you'll see a lot of information coming to you. After the webinar, we'll have a final word, but also we hope that you will be able to fill in some questionnaires so that we can learn from you and so that we can help you and your customers in order to drive efficiency in their OR. I also welcome a lot of people from the orthopedic industry to this webinar. So we have actually a heterogeneous group, surgeons, nurses even, but also people from the industry. Please contact us if you think that we can help you driving efficiency in the OR of your customer. So let's go to the first presentation. Jeroen is now dealing.
The efficient surgery concept to conduct primary total hip arthroplasty has been introduced in our OR over the past 5 years. The efficient direct anterior hip is actually the result of critically evaluating the whole OR process to conduct total hip arthroplasty through the direct anterior approach. It is our duty as surgeons to try to tackle one of the most important issues in healthcare today and tomorrow, which is sustainability. Sustainability from an health economic perspective, health ergonomic perspective, but also from a perspective with an improved quality of care for our patients. The European Commissioner for Health and Food Safety stated in his 2017 report that there is a huge burden for our healthcare. The main question is, how can we actually keep healthcare affordable and timely accessible with better outcomes for all our patients? It is clear that the aging population is one of the most important threats for our healthcare system. Today, approximately 17% of the population is older than 65. In 2050, it is estimated that 28% of our population actually is over 65 and older. In a recent survey, it was clear that physicians think that the aging population will actually be the biggest catalyst for change in the next 2 years. 83% of the physicians see this as a threat, and 42% actually believe that it will impair the ability to deliver the same quality of care as today. So therefore, there is a major challenge to try to tackle the tsunami of the aging population and all the pathologies that come with aging into our society. As a result, in the world's most demanded professions, we can find that nurses and doctors actually are one of the most important professions in order to keep our healthcare sustainable. It is clear that there is an increase in nurse vacancies over the past years, plus 18% in Belgium, plus 26% in Germany. And as a matter of fact, it has been calculated in Germany that by 2025, plus 180,000 healthcare practitioners are required in order to keep the quality of care in Germany to the top level. So therefore, we have to try to tackle this demand of staff in order to keep quality of care as high as possible. I strongly believe that we surgeons and surgical teams actually need to create innovative procedures to optimize our surgical processes with a minimum of cost, a minimum of manpower, and a reduction in OR times. And this in order to improve a maximum level of quality of care. And this can be done in two ways. First of all, we have to try to treat as many patients as possible with a minimum of treatment effort. But we have to treat as many patients as possible with a maximum of treatment reproducibility. This can be done through the direct anterior approach. We do know that total hip arthroplasty is one of the most successful procedures in the world. However, also for total hip arthroplasty, there is a major challenge. There is an increase in numbers of cases over the next 5 years to approximately 112%. But on the other hand, we do know there's an increasing demand also from our patients. Patients are getting younger, getting more active. And at first glance, it looks that both challenges actually are contradictory to each other, but I do not believe that that is the case. It is because of the direct anterior approach that I do believe that we can deal with both issues. It is due to the direct anterior approach that we can find a solution to this increasing demand for improved outcomes. This is a patient who had a bilateral direct anterior approach done. He's a young guy. He's a karate trainer. He comes to my clinic 3 months after the procedure. And he asked me whether he's allowed to do these stretching exercises 3 months following his direct anterior approach, bilateral total hip arthroplasty. This kind of demand is what we have to really deal with for our patients today and tomorrow. However, trying to do the direct anterior approach and allowing this kind of demand for our patients was actually a challenge in the beginning. When I started the direct anterior approach, it was clear that I was faced with increasing expenses and insufficient manpower. In the regular direct anterior approach, in the traditional way as you see it here, we needed 4 people in the room. People were holding retractors, but also the amount of instrumentation trays was quite high. So therefore, it was really and definitely not an efficient approach, neither from an ergonomic point of view, nor from an economic point of view with this amount of trays and this amount of manpower. Today, we conduct a direct anterior approach with only 1 scrub nurse. We have reduced the amount of trays, we have reduced the amount of manpower, but we also have reduced the economic burden of the procedure because the sterilization costs have been reduced, but the procedure is still muscle sparing with an improved outcome for our patients due to a reduced surgical trauma. Now the question is, how did we actually do this? Back in 2013, we had a redundant amount of people in the room, and today we were able to triple the amount of cases actually with the same resources. How did we do this? This is what this webinar is all about. We rationalized our instruments, we standardized our OR setup, we standardized our procedure, but we also monitored the quality of care. This is what we call the Efficient Direct Anterior Hip, or the EDA hip. We introduced 3 keywords. Simplicity would lead to reproducibility, and in the end would lead to efficiency, in order to deal with all the issues that are particular of interest for every different stakeholders of the whole process, including the patient, the surgical team, and the hospital. How did we actually do it? The surgical team, along with hospital management, sat together and critically evaluate how we could rationalize and standardize our procedures. This required some investments from the hospital end, but also efforts from the surgical team to critically evaluate what we were doing. Because we knew that when we would do this, this would pay back to an improved quality of care for our patient, improved ergonomics and for the surgical team, and improved economics for the hospital. The improved ergonomics are actually the key for the whole process improvement. Because of improved ergonomics, quality of care would go up as well. Due to improved ergonomics of the team, the mental exhaust would go down, and the risk of inaccuracies would go down as well. Physical exhaust would go down, and therefore the occupational hazard risk would go down as well. In line with this, the OR time goes down and surgical trauma for the patient goes down. So therefore recovery is enhanced. But also people can be reallocated and would therefore be more motivated. The end result would be that we reduce our complications, we reduce our hospital stay, increase the volume in the OR and the ward, and this would at the end pay back to the hospital with improved economics. This algorithm successfully was introduced in our OR over the past 3 to 5 years. And this is how we also would like to help you in order to bring efficiency into your OR. Some practical examples. Back in 2013, we had a very cumbersome draping sequence. Not only was this from an ergonomical point of view cumbersome and definitely not efficient. You can see the nurse holding both legs of the patient there in a non-ergonomic position, but also because of the draping sequence, there was a high risk of contaminating the surgical field with an increased risk of infection. Draping time took us about 15 minutes. Another issue was retractor variability. Because we had 4 people in the room holding retractors, retractors were moving around. This would lead to increased muscle damage, but also would impair the view of the surgeon. An impaired surgical field actually would lead to inaccurate and improper component positioning. But also here you can see that the discomfort for the surgeon is very high. This is a non-ergonomic position of the surgeon to do the direct anterior approach. We had to find solutions for this problem. Therefore, we created a multidisciplinary integrated platform for rationalization, standardization, and monitoring of the anterior hips. We brought together every team member that was involved with the process, starting from our anesthesiology colleagues, our nurses. We also had involvement of the industry, allowing us to use instruments that would make our OR more ergonomic. We also involved the industry who provides us with the implants so that we were able to reduce our sets, but this could only be done with the guidance of another industrial partner who allowed us to monitor what we were doing and allowed us to clearly and critically evaluate how we were doing it.
The Efficient Direct Anterior approach to conduct total hip arthroplasty, also known as the EDA total hip, is a very new, innovative way of conducting total hip arthroplasty through the direct anterior approach.
The use of regional anesthesia and acute pain management by regional anesthesia has created an environment for rapid recovery and extremely efficient operating room environment in which the patients not only get regional anesthesia for entire surgery intraoperatively, but also carry the benefits of regional anesthesia postoperatively to enhance the recovery and acute pain management.
The efficient direct anterior approach replacement concept has really improved the comfort for the surgical team, has diminished the soft tissue damage during the procedure, and has increased the turnover in our OR. Sustainability in healthcare is the most important thing that we should really focus on over the next years. With the efficient direct anterior approach hip replacement surgery, we have been able to increase the turnover in our OR, we have been able to increase the turnover in the ward, but most importantly, we have been able to increase the quality of arthroplasty surgery. This concept has allowed us to dramatically change the workflow in our OR. It is a team effort where anesthesiologists, nurses, and the surgical team closely work together in order to improve the efficiency of care of our patients. It also allows us to make healthcare sustainable. We are able to do more with less, but more reproducible and more efficient. How did we introduce the EDA hip into our OR from a practical point of view? We used the three keywords: simplicity that would lead to reproducibility, and at the end also to improved efficiency. Simplifying all the different aspects of the procedure would lead to an increased reproducibility. And it started with rationalization of our instrument trays. I've been using over 4,000 Pinnacle implants, and I critically evaluated, along with my nurses, all the instruments that we really use, but we also evaluated which components I actually use over more than 2,000 cases. We used the artificial intelligence technology of Dille to screen my OR reports over the past 2,000 cases. And we evaluated which components were used in 97% of all my cases. And based on that, we were able to define two trays that actually cover all the instruments that we use in 97% of the cases. Both trays include instrumentation such as forceps, scissors, but also Pinnacle implant instrumentation. This resulted in a reduction of logistic volume, but it also reduced the sterilization cost per case to only 150 euros. There are 3 trays used, 1 for power tools and 2 for OR instruments. This is a brief overview of the instruments that we use. We use 5 retractors with a specific soft tissue sparing morphology. And we evaluated that for the stem, we don't go in a stem size higher than 16 for the cry, for example. So all the largest stem sizes were discarded. Similar to the socket, we almost never go in a socket diameter above 58. Therefore, we discarded all the graters that were smaller than 58. This allowed us to define a very efficient instrumentation tray. Also, the OR setup has been standardized significantly. We use fixation points on the ipsilateral and the contralateral side of the patient. These fixation points are important because they are mounted on the table and they allow us to use a self-retaining retractor system that is modifiable throughout the procedure. The patient is supine, the patient is already prepped, and then draping has been made very efficient. We today use the Easy Suit. The Easy Suit that is produced and distributed by MedEnvision allows us to drape in 1 minute. But most importantly, it is standardized, the draping, and there is a minimum risk of contamination of the surgical site. Time to incision was approximately 11 minutes in the traditional setup. Today, time to incision is 5 minutes, or in other words, we have the femoral head out by the time that we were making the incision 5 years ago.
Reproducibility is important, and it all starts with a standardized procedure. A procedure that is constructed in 3 major steps: capsule exposure, capsule release, and component insertion. This is very easy to understand for the nurses, but also to train residents and fellows and surgeons who want to use the EDA hip. But retractor placement has been standardized as well. We all know how difficult it is for an assistant on the contralateral side of the table to understand where the retractor needs to be held. Therefore, we use a smart device which is called the gripper. It's a disposable device that is mounted on the retractor and is also connected to the fixation post on the sidebar of the table. This device allows us to conduct the surgery with only one scrub nurse or with only one assistant, but provides me a sufficient view on the femur and the acetabulum. So therefore, quality of care is not jeopardized despite the fact that we do it in an ergonomic, more efficient way and with less manpower required to conduct the procedure. So the gripper is mounted to the retractor, is connected to the fixation posts on the contralateral and the ipsilateral side of the table. And because the gripper uses 2 strings and the soft tissues as a third fixation point, the gripper is inherently stable. It allows the surgeon to have a perfect view on the acetabulum and the femur, and it allows the team to work in a much more ergonomic way. As a result, the mental exhaust and the physical exhaust of the team will go down, and therefore the procedure will go much more smoothly. The surgeon pushes the blue button of the gripper, positions the retractor in the perfect position, and the retractor stays there in an inherently stable position. We have a nice view on the capsule, as you can see here. This is a short overview of the full procedure. In this example, we use the bikini incision, which is 3 finger breadths distal to the anterior superior iliac spine. We then identify the TFL, open up the fascia of the TFL, and we identify the vessels, which are in the middle of the incision. We put the superior retractor between the minimus and the superior capsule. The inferior retractor goes over the calcar, and the lateral retractor retracts the TFL in the lateral direction. The anterior retractor is positioned underneath the iliocapsularis and is directed towards the contralateral kidney. We open up the capsule. We don't excise the capsule. This is a capsular flap retention technique. We have a nice view on the femur. We put in our corkscrew in the femoral head and then make our neck osteotomy just medial to the intertrochanteric ridge. The head is easily extracted, and then we release the inferior capsule or the pubofemoral ligament. The superior capsule is released as well in a very systematic way, and it pulls the femur in the lateral direction. Once the femur is released, we push down the femur in the posterior direction with a posterior retractor and a posterior inferior retractor. We use anatomic reaming. That means we don't medialize, but we actually try to only ream away the cartilage and the hard subchondral bone. We put in the socket, next the liner, and then we move on to the femoral elevation strategy. The bone hook pulls the femur up, pushes down the soft tissue, and we bring the ipsilateral leg underneath the contralateral one. This is done by the nurse on the contralateral side of the table. We put the retractor at the level of the calcar. The gripper holds the retractor in a stable position, and then after the broaching is done, we can evaluate the stability of the implant with hyperextension external rotation, but also deep flexion internal rotation. We bring the stem in, and then we reduce the femoral head. We have a nice stable reconstruction, and we close the capsular flap. At the end of the procedure, the joint is nicely closed, the fascia is closed, and then finally we close with intradermal stitches or with preneo. Does this really lead to an improved efficiency? For the hospital, clearly we were able to reduce the manpower to conduct one procedure, and we were able to reduce the sterilization cost dramatically. So yes, for the hospital there is an economic burden, an economic incentive to introduce the EDA hip. But also with the same resources, and actually with less resources than before, we were able to triple the amount of cases over the past 4 to 5 years. There was direct cost saving of 250,000 euros on an annual basis for our hospital. But also for the surgical team, it is important to improve ergonomics in order to improve quality of care. Due to the improved ergonomics, mental and physical exhaust go down, OR time goes down, and manpower could be reallocated. This at the end led to an improved quality of care due to less inaccuracies, less occupational hazard, less surgical trauma to the patient, and more motivation of the staff. And this is at the end important for the patient. He or she wants to have a perfect procedure with a minimum risk of having muscle damage. They want to recover as quickly as possible. They want to leave the operating room and want to start their new life without pain. We have also used an application for our patients so that patients are well informed. Patients are perfectly informed so that the recovery can start immediately after the surgery. They also have access to videos on the application. These videos are videos that give them information about how to recover, how to really prepare themselves at their own place when they go home. This allows us to have a fast-track hip replacement procedure. But also, our patients are requested to fill in patient-reported outcome measures, and the application screens the complications of all my patients behind the scene. This is done with the Dille artificial intelligence technology. And this allows me to really follow my patients and to really follow my patient population. And this is at the end very important. Monitoring to what we are doing is critical. For example, due to the patient application, we perfectly know that 85% of patients recover perfectly. We had a 0.5% reoperation rate, a 0.3% infection rate in 613 total hip procedures in 532 patients. We had a 0.3 revision rate. And when we compare this to the benchmark from the US National Registry, it is clear that the infection rate there is 1% in comparison to 0.3 to ours, and the revision rate is 2.9% in comparison to 0.5 in ours. But also patient-reported outcome measures are followed. We also asked the patients for the forgotten hip syndrome, and it turns out that 80% of the patients have most of the time a completely forgotten hip, 20% do not. There are several lessons learned from the introduction of the EDA hip and the evaluation of my peer-to-peer training program. The easy concept for the anterior approach hip or the EDA hip resulted in reduced cost, increased volume, and improved team ergonomics and improved outcomes as well. It is highly reproducible with outstanding results due to the fact that we improved the ergonomics. A successful introduction of the EDA hip requires a customized approach based on the needs of the surgical team and the hospital, and that's really critical. We have learned that introducing the EDA hip requires really a team effort, where nurses, anesthesiologists, and the surgeon follow a dedicated training program, which covers all different aspects of the surgical process. And this is really critical. Many surgeons visited me, and they were inspired by what they saw. However, they did not know how to transplant this to their own hospital. That is why we introduced a new and innovative training program that I will present to you in the next presentation. The efficient surgery solution is actually a solution that helps surgical teams to introduce the EDA hip in their OR. It aims to help, guide and train the teams during the preparation, introduction and the execution of the EDA hip. It focuses on clinical implementation and training of the EDA hip, and it provides easy services with efficient surgery software, as I will show you in the next presentation. Thank you. With the easy solution, we aim to provide an integrated, customized training platform to those surgeons and surgical teams who want to introduce the EDA hip in their OR. Peer-to-peer training is crucial. However, a successful introduction, in my opinion, can only be done in partnership with the industry. The industry where major efforts have been undertaken already to improve ergonomics in the OR of many surgeons. It is due to support of MedEnvision, Dille, and also the Biosynthesis that we have been able to successfully define an integrated training platform. The main question is, how can we really help surgeons to improve the efficiency in the OR from a traditional anterior approach towards the efficient anterior approach, where only one scrub nurse is helping the surgeon from an economical, correct and efficient standpoint of view, but also the surgeon can conduct the surgery in a very swift way with a perfect visibility of the different components. It is by defining an innovative, multidisciplinary and most importantly customized training pathway that we want to help you to safely introduce the EDA hip into your OR. The surgeon should not be left alone when he wants to introduce a new technique in his OR. He should be supported by his nursing staff, should be supported by an anesthesiologist. When all the team members are already well aligned, they will be able to absorb the learning curve much more efficiently and much better than when the surgeon has to do this on his own. Therefore, EDA training is really central, but this should be supported and can be supported with the EDA software and the EDA hardware. Because it is customized, surgeons can choose whatever part of the training program they want. The whole customized training program consists of different phases. In the first phase, the surgeon has to decide whether or not he wants to commit his surgical team to the training program. Once this is done, a customized EDA training program can be defined along with the surgeon's need, along with the need of the hospital and the needs of the surgical team. The team will be prepared together. A visit of the team to an EDA reference key opinion leader is possible. But then also, introduction of the EDA hip in the center of the surgeon will be guided as well. Finally, surgeons will have feedback. They will get feedback from the whole team that has supported them to introduce the EDA hip in the OR. And I think that this interactive, multidisciplinary approach is probably the best way to try to successfully introduce the EDA hip in many surgeons' OR. It is important that surgeons are guided by specialists who have been introducing the EDA hip already in many ORs. So defining a customized training program is crucial. The whole training program consists of multiple steps that are focused on different aspects of the whole training. It starts from preparation and goes over a 3-month period approximately. Smart training is introduced. With smart training, the team will be trained at their own place together as a team. New technologies have been developed for that. Live training with cadaver training is provided as well. But we also need to measure how the efficiency is improved. Efficiency with regards to the instrumentation trays, regards to the OR setup, but also with regards to patient-reported outcome measures. What about the smart training? I think it is important that not only the surgeon is trained, but that the full team is trained. In order to achieve this, we have developed a website, we have developed a special deferred live surgery application, we have defined a VR module along with the Biosynthesis, and we also have defined a haptic device. On the Easy Concept website, surgical teams can register. The website consists of 45 videos so far, starting from explanatory videos about the rationale with cadaver videos, the whole procedure in multiple videos of only 1 or 2 minutes so that every step of the procedure is discussed. Also advanced procedures such as revision surgery and extensile femoral approaches, but also videos that are focused on the team, focused on the nurses and their job throughout the full procedure. It is crucial that the full team, that all the team members are trained together. We have also installed and created what we call deferred live surgery application. This is an application that brings the OR to your own setting. 5 different videos are reported in this application. Every step of the procedure is filmed by multiple videos. The surgeon can go through every different step of the procedure, can zoom in, can focus on the different aspects of it. 5 different procedures are recorded. With this 360-degree camera, you can overview the full OR setup. With this new application, it would be of interest to train every team member so that everybody understands the position of the different team members throughout the procedure, but also can better understand the different steps of the procedure. Because the whole procedure can be filmed from different angles, everybody can really focus on its own task. Because all the videos are synchronized, we have added a 4th dimension towards this filming. It is a time dimension. The time dimension that allows everybody to understand its position throughout the procedure. We have also used a highly detailed camera. A camera that can help the surgeon to really focus on the crucial steps of the procedure, such as, for example, the superior capsule release. With this camera, the surgeon can zoom in and he can really focus on the superior capsule release that you can see here. It's a highly detailed video recording of every different step of the procedure. Therefore, the surgeon can train himself, can train the team. The procedure has been divided in multiple steps and can be overviewed in different ways. Every procedure has got a different aspect to it. Some procedures focus more on the surgical detail, other procedures focus more on the overall OR setup. We have also developed a haptic device. This device with a 3D glasses focuses on the superior capsule release. This haptic device will be used as a training device in our cadaver courses. And indeed, it is important that the teams are being prepared. We have an EDA bootcamp, a bootcamp that focuses on different aspects with local regional anesthesia, but also reaming the socket, the OR setup, where all team members can be trained. The first bootcamp will be in Hamburg in the 1st of April. It is supported by the Pew Synthes. But later on in this year, in June or September, we'll have another bootcamp where all surgeons and surgical teams are invited to participate. Team visit, of course, is important. We have different reference centers in Belgium and in the Netherlands and France. These reference centers can be visited, and it is based on the preferences of the surgical team that different reference centers can be visited during 1 week. Of course, introducing the EDA hip in your OR needs to be supported by EDA specialists. These specialists not only know everything about an efficient OR setup, but also can help you through the details of the procedure. And they are your guides in order to have a successful introduction of the procedure in your OR. But on the other hand, we need to do measurements concerning efficiency. And this is supported by Dille. Dille will provide software and will support the hardware in order to make your OR from an ergonomical point of view more efficient. Patient application and the surgeon application is provided. With the patient application, you will be able to monitor your patients, as was shown previously. This allows you to monitor your quality of care as well. With the surgeon's application, we'll be able to, on a customized way, introduce hardware into your OR so that you can become more ergonomic. This was exactly what we did also in our OR, but this can only be done based upon your own OR reports so that you do not have to change your implant sizing or you do not have to really modify your surgical technique with regards to your components. Hardware is really crucial in introducing the EDA hip into your OR. It is crucial to have a standardized draping technology, to have a standardized retractor placement. But also it is crucial to reduce your sterilization costs. In the end, what we want is to have a successful introduction of the efficient surgery concept and the EDA hip into your OR. An integrated training platform is therefore important. This can only be done with the support of the industry. We focus on training, but we use software and hardware to successfully introduce this new technique into your OR.
Thank you, Professor Corten, for this excellent and interesting presentation. Good evening, everybody. This is Jeroen Dille speaking. First of all, I would like to thank all of you to take out time of your busy schedules to follow this webinar. During the next 15 minutes, I will explain how our company Dille can enable you to implement the efficient direct anterior approach in your hospital, allowing you to treat more patients at a lower cost and with optimal quality of care. The easy solution has been co-developed by Professor Corten and Dille together with our technology partners like Linkscare, DLifeMed and many others. The solution has been fully validated and proven over the past years at Professor Corten's practice in the Ziekenhuis Oost-Limburg. As Professor Corten explained, the easy solution is a comprehensive technology and services platform that contains everything you need to reach similar results in your own practice. The solution consists out of 4 components: our software platform, the MedEnvision medical devices, our OR efficiency services platform, and our training platform. Since Professor Corten already showed some of the software applications we use, as well as the MedEnvision devices and the training platform, I will zoom in during this presentation on the OR efficiency services. Our OR efficiency program starts with an intake where we will look together with you at the total cost of ownership of hip surgery at your facility. We have developed an easy calculator that allows us to capture some key parameters about your practice as well as your key objectives. And from this information, our calculator will provide a first indication of the impact that the easy solution could make on your case volume, your labor cost per surgery, your material cost per surgery, and on the ergonomics in your OR. After the kickoff, our OR efficiency process is initiated. The process starts with a data gathering and fact-finding phase, which takes about 1 week, during which our engineers will come to your hospital to do measurements and interviews. We analyze this information, compare the data to our benchmarks, identify opportunities for improvements, and also calculate the return on investment for your hospital. Based on the data we gathered and the goals of the different stakeholders in your hospital, we propose a tailor-made implementation roadmap. This roadmap is discussed in detail with you to ensure we are fully aligned. And obviously, we will propose to start with the changes that make maximal impact. Once we reach an agreement, implementation will start. In our experience, a first batch of improvements takes between 3 and 5 months to fully implement. Finally, after this first implementation, our engineering team will come back to your hospital and will take new measurements to calculate the actual return on investment for your hospital. Also, future opportunities for improvement will be identified for a possible second iteration. After our last webinar, we received quite some requests to talk about the data points we will gather and what typical changes we will make during our OR efficiency program. So allow me to provide some additional details related to the data gathering and fact-finding phase. First of all, during this phase, we will perform stakeholder interviews, which are standardized interviews to uncover opportunities for improvement, but also to list out the desired outcomes per stakeholders. We will interview your hospital managers, your head nurse, your colleague surgeons, your anesthesiologist, the pharmacy and purchasing manager, and the sterilization department. Secondly, we will do a retrospective analysis of your implant usage and the quality of care by data mining your electronic patient records. We work together with our partner Linkscare to do this in a very efficient way. This information will provide us with a baseline of quality of care, but also the information necessary to reduce your instrument trace. Thirdly, we will do measurements inside the OR for about 5 to 10 surgeries per surgeon. These measurements will allow us to capture your OR flow in detail and measure ergonomics. We will take more than 50 data points, allowing us to map out your OR flow and assess both standardization and efficiency. In the graph below, every line is a patient, the vertical axis is the time, and the horizontal axis depicts every action in the setup of the OR. And you can see very clearly, once you start measuring these actions very detailed, that the second half of this process has been standardized nicely, but that there is still some work to do in the first half of the process. With this information, we can map out the average in and out time for the patient, as well as the manpower active during the OR flow, allowing us to optimize both in and out time as well as labor cost. Ergonomics are measured for the instrument nurse. Both dynamic and static ergonomics are measured and compared to our benchmarks. Also here, opportunities for improvements are assessed based on the data that we capture inside your hospital. Finally, we will also look outside of the OR, investigating opportunities of improvement in your consumables, implant stock, and instruments. We'll also assess the physical and IT infrastructure because these could either limit certain changes or accelerate efficiency gains. All this information is then analyzed by our engineers to come up with a tailor-made roadmap for your particular process and your particular hospital. At this point, we're signing up new centers to go through the first steps of the program, namely the data gathering, fact-finding, and the analysis phase. If there's any interest to receive a proposal for your center, feel free to contact me at jeroen@deo.care. Thank you very much for your attention. With this, I will give the word back to Professor Corten.
Okay, so these were our presentations, and these presentations actually were intended to give you a little bit of a clue of what we want to achieve and what we can offer to you, surgeons, surgical teams, and also to the industrial partners who have followed the webinar. I think it is our goal, as I said before, that we will initiate more webinars later on. We will also have a boot camp somewhere at the end of June and also probably September, October, a boot camp where we invite surgeons along with the nurses, with the anesthesiologists, to come to our hospital so that we can do live surgery, but also cadaver training with the haptic VR instrument that we have developed, also training with the deferred live surgery application. And in preparation of this boot camp, we will have other webinars that will focus on different aspects of the EDA hip so that the full team can really be prepared. So I think that this is a new innovative way of training surgeons, but also surgical teams. We really think that commitment of the surgical team towards this process is really crucial, but more information will come later on. One of our first boot camps will come now as well in partnership with the Biosintis in Hamburg next Monday. So I am really excited about what we will learn there from our surgeons and surgical teams. And I think I also would like to thank the Biosintis to provide us this opportunity to, along with them, do this innovative and creative boot camp. So this was basically it. We will send over a questionnaire to you later on. We would really appreciate if you could fill in the questionnaire. For surgeons, please let us know what you want to be covered in the next webinar. From representatives from the industry, please let us know what you want for your customers that we tell them. And we really look forward to see you later on. We really welcome you to the next webinar. Thanks for the attention. Have a good day and a good evening. See you later. Bye.
Bye.